May I just say, you do wear a number of other hats. I know Richard is a chairman of a trust. He was previously the chair of the Strategic Health Authority. So if you want to go outside that remit, please, any insight you may have what this commission could do in London will be gratefully received. So I'll leave it to you.
Just listening to the other speakers, I think there are a few things that people need to recognise. The healthcare market in the UK is about 3.5% of the world healthcare market.
Yeah.
The United States is 35% of the world healthcare market. So there's a market. That's why there's a hell of a business there, because they see a market. And it's a market that embraces innovation. It supports innovation, it pays for innovation, and it goes for innovation. We have exactly the opposite. We don't like innovation, we don't pay for innovation, and it takes us a long time to bring new innovation into the marketplace. I think that's an important part to recognise. We also recognise we've been down this route many times before in trying to say, why isn't London the great capital of the healthcare industry and the life sciences industry? And again, I think it's important to understand history. And the life sciences industry, the pharmaceutical industry, really took off in this country in the 1960s. And it was penicillin, it was the development of penicillin, along came the cephalosporins, all through Oxford University, all working with industry through the university, working together, that actually started to develop that industry. Pharmacologists came from Europe, we didn't actually train pharmacologists in this country, and so you started to develop. But the clever thing was, there was an incentive. The governments of all parties agreed on a process, and they introduced something called the PPRS, the Pharmaceutical Price Regulation Scheme. And that said, if you do research and development in the UK, you put your businesses here, you can charge whatever you like for your drugs, your new drugs, and then at the end of the year we'll balance off what you pay for in R&D against the relief that we'll give you. That encouraged most major pharmaceutical companies in the world to put their R&D in the UK. And over time, of course, that's been eroded. Every government has hated it because they've said, look at this big fat industry, making lots of money, employing lots of people, good for the UK economy. Let's kill it. And so, as you know now, it's been phased out and we end up with the patent box, which is different. We also had an NHS which was a wonderful testbed for doing clinical trials. When I was a boy, 11% of clinical trials used to be carried out in the UK. Today it's less than 3%, because there's been an we don't want industry doing their studies in our hospitals. So that's the second one. The third one is, we used to produce graduates. They didn't go into the city, as we heard the Deputy Mayor say, but they went into life sciences. And so if you were a company, you could employ really smart chemists, biologists, clinicians to work in these industries. So those three factors, along with the PPRs, attracted industry to come and put its R&D in the UK. As those have been eroded, those industries have disappeared. The research has been put in other parts of the world. Clinical trials now are done outside the UK in the great majority of cases. And now we're trying to bring it all back again. It is very, very difficult. Once you've lost something, it's quite difficult to bring it back. And I just think we ought to understand where we're coming from before we start to decide how we're going to go forward.
Thank you. Thank you. Good. Very.
Shall I just make some introductory comments as well? I think we heard in the previous contributors' remarks some issues around structure and culture. And I would just sort of counsel that we do have structures, and indeed there's a danger that we see the solution as more structure. I think with the AHSCs, the AHSNs, powerful universities that are producing very good life science outputs in an academic sense, it signals that we don't need more structure. We need to be able to network better that which we have and actually use elements of those institutional bodies that can subserve the needs of the whole. So, for example, in UCL Partners, where I'm academic director of the Academic Health Science Centre component, we're deliberately using the university's translational research office, research coordination expertise, rather than creating another structure within the academic health science centre to deliver that end. In terms of culture, then I think Sir Richard's right. There is clearly a difference between us and the States in terms of the way that entrepreneurship and innovation is gripped, and that's the biggest challenge for us, to embed an ownership of the need to conduct smarter innovation. And by smarter, I mean innovation that is going to bring incremental benefit to our health economy, not just producing things for their own sake. That needs a deeper appreciation of value, a deeper appreciation of what genuinely matters to patients and citizens, and slicker processes for getting those developments through from discovery to adoption and diffusion within our communities. So I believe there needs to be a holistic approach to that innovation cycle. One of the reasons why we're partners with Oxford University in the Centre for Advancement of Sustainable Medical Innovation is to view all of those steps in the innovation chain and bring the totality of academic endeavour, ethics, law, regulatory science, as well as biomedical research to bear on those issues so that we come up with a more effective innovation pipeline. I think to affect the culture, we also need to encourage, as universities, much greater permeability between industry and academe, and there are responsibilities on both sides, I think, to realise that, so that we reward people within the university system who've gained industry experience and are producing outputs from that work that perhaps wouldn't typically be recognised against an academic yardstick. And in that way, we can break down the cultural differences between the sectors, because at the end of the day, we should all be working for the common good and for the health and economic benefit of our society.
Well, that's fantastic, and I think both of you covered different things. I think if I could come back to Richard's point, which was mostly about inward investment, and I think what you've suggested is how do you make the soil more fertile in the diffusion and the adoption of these innovations, and I think that's been the main focus of debate in recent times, to be honest. But I don't think we've heard as acutely the issues in related to inward investment in the life sciences industry, and you did say that it's gone elsewhere. Have elsewhere provided certain incentives that are different than the incentives we had here? Are they doing, what's attractive? I mean, is it because of size? Like China could do a clinical trial because of its size? Is it because of incentives, financial incentives? Is it tax issues? And how do we compare now with, I don't know where these countries are, I presume Singapore, it's mostly the Far East, and am I correct? Or
But it's back to markets, you see. Phase 1 clinical trials are quite small, they're quite intense, you need a lot of kit, and so we should be doing all phase 1 clinical trials, if you like, in this country. But that is very sort of academic clinician, scientist type stuff. Once you get into phase 2, phase 2A may be the same, get into phase 2B, phase 3, you start to look where the markets are, because you want to educate the people in the market where you're going to sell your product. Sure. And so the phase 3, phase 4 studies will be carried out in potentially big markets. Yeah. And recognise, although we've got some collaboration, you still have to do certain clinical trials in Japan, irrespective of whether you've done them elsewhere on Earth. Yeah. You're probably going to have to do clinical trials in the Far East because it gives them a feeling that you've done the studies in that population of patients who are, by definition, genetically a little bit different. Yep. So that's what's driven it, and if there's no great incentive like the PPRS or the National Health Service anymore, then it doesn't matter where you do your clinical trials, except for the phase 1, which is critical stuff, and the phase 2A, which is critical.
And with the recent strategy of the 100,000 stratification of patients, would that be an attractive offer to bring them back? I mean, I don't think any other countries...
I think it's very attractive if you can start to make sure that they can have access to them.
That data.
And we don't create an enormous bureaucracy, and we don't put lots of barriers in place.
Okay.
I mean, until we got things like the Cancer Network, it's still a nightmare to do big clinical trials in the UK because getting coordination, it's very, very difficult. The networks allow us to do that, but in other areas. So I think with the academic health science centres and the networks, we can offer that, but we have to work together. We have to collaborate together, not fight each other. If we work together in London, we can beat anybody else on earth. But it's that collaboration that's critically important.
Thank you.
And I think that spirit is growing over the last 3 years. We've seen much closer collaboration between the 3 academic health science centres, which extends with their networks to a population of 8.5 million. So I believe we've got there. And of course the MedCity proposal brings that together, creates something very tangible out of that level of collaboration.
But again, I think it's also important, and I think I heard somebody else say this, that we get our own house in order. Healthcare for London was a very critical programme to make sure that we are delivering good healthcare, not just to a certain population in Chelsea and Westminster, but also in Dagenham. And so we need to make sure that we've got a good healthcare system operating in London before we say to others, right, come here, because this is the perfect situation. And again, we have a great opportunity to do that, but we're still not doing it because it's been put back 3 years because of all sorts of political interference. But we've got to localise where localisation for medicine is correct. We've got to really get decentralisation. We've got to get centralisation where that is also critically important, like the hyperacute stroke centres, the trauma centres, the cardiac centres. And then at the other end, we've got to have integration. We've got to integrate care pathways that make it nice and smooth for people to get well integrated care as opposed to moving from pillar to post to pillar to post. And once we can show that, then you'll start to attract people to say, wow, this is a fantastic place.
And key to realising that goal with, if you like, pinnacles of excellence, the academic medical centres where the discovery and the innovation generates from, and diffusing that to benefit the broader population, we clearly need the very best informatics and deal with a real deficiency. And so, in the sense of what London needs to get behind, its support for that agenda, because we can't deliver the contemporary approach to science, the interrogation of big data sources, access to people by genotype, phenotype for the sophisticated studies, unless we have that, framework.
Thank you.
Wow, Richard, you laid out a great exposition of why it was good in the 60s. Do you think it's impossible to get it back, or could London, through the Health Commission and Boris Johnson, actually do something to recreate the impetus that you very elegantly described existed once upon a time here?
I think if you want to get it back, then you've got to offer something. And the offer would be getting healthcare in London sorted out. And I think if the Mayor would take an interest in that, and I can understand why he might not want to get involved, but I think taking an interest in delivering healthcare to the citizens of London is a mayoral responsibility, because it is a city and it's different from the rest of the UK. We have to understand that. I think one of the other deficits that we've got is good private healthcare. People come from all over the world to this city, but they still go to Minnesota to have their checkups. I mean, it's mad. Why would you want to go to Minnesota if you can come into one of the greatest cities on earth and have it done here? But we still don't have that offer. So I think that's where we need to get our act together as well, and stop worrying about we've got private healthcare, we've got public healthcare, but they work side by side because there are two completely different markets. And so I think if you started to do things like that, send some clear messages that we mean business, then you'll start to attract people back.
Brilliant, thank you.
Thank you. David.
I've got two questions raised by your presentations. Richard, you really made the point, you lose something, getting it back is very difficult. And I wanted to ask you really about attracting the talent of trainees and education, because London's had a strong brand for that for a long time. You could argue it was one of the few pillars left, the things that haven't been taken away, particularly at the top end of the market, you know, the 1 or 2% that will make this global difference. Have you got any thoughts on how together the big players in London could ensure that that offering is better, either for very bright people across the country or internationally, so that we don't lose that too?
You see, if you look at the forerunner of the academic health science centres, it was the Hammersmith, wasn't it? The Hammersmith Postgraduate Medical School was, in a funny sort of way, an academic health science centre. It attracted some of the finest people in the world, and they went there to do their postgraduate medicine. So I think we have that potential now in London for training and development. And if people saw that we had this great potential to come here for the training and development, we would attract again the best and brightest, and many of them would stay and work within the system. And I think that happens in academia to a great extent. But I think if we can start to, and particularly the academic health science centres, because they're an integrated sort of the NHS along with the best of the academic side, then I think we have a great potential to do that. So training and development, and show that we can actually do that better than anybody else, because people recognise that it's still very good, as you say. But if we coordinated it and brought that back, then I think that might be critically important.
But perhaps it's also under as much threat as the other three at the moment, which John might want to
I think there are two major threats. One is, of course, the expense of living in London for trainees, particularly non-clinical trainees. So ways of mitigating those costs, creating environments where people can come early in their career to get that essential experience and be attracted to stay is important. I think what you're alluding to, David, is the model for distribution of clinical trainee posts based on a capitation, which denies the fact that we need more to subserve both the health need and take advantage of the superb clinical academic training opportunities. And we're seeing the ridiculous situation, quite frankly, whereby we can't fulfill our training potential in academic clinical training because of that model.
So I was really looking how much London could work together, so we didn't either dismantle what we already have, following your previous comments, Richard, or actually make it better by working together across the capital rather than internally competing. Because I don't have a sense of the collectives thinking, how can we recruit and retain this top 1 or 2%? I have the sense each one wants to do it separately, quite rightly, for their organisation, but no sense that we're creating programmes collectively that would be so attractive. And I sort of have heard you acknowledge that, John.
I think there's some evidence that happens. I think we could do far more of it. I think in terms of the collaboration between the three AHSCs, the focus has been on research, collective capability, and we need to attend better to the educational piece.
And I guess a capitation model could see a reduction of, many tens of percent in
Absolutely.
terms of training money in London.
Absolutely.
And we should be realistic the impact that would have. The second question was about the scale of collaboration. So, Richard, you raised the point, we're only 10% of the US, 3.5, 35%. So for the very big ticket items like informatics, which may be such a big part of the industry going forward, there will be things perhaps which London is too small, where we would need the whole of the UK to collaborate. I can see there are some things where London could collaborate well together with enough critical mass, some things where that might embrace Oxford and Cambridge, many things. And I just wondered if you'd each reflect on, but where are the things where actually the global competitors are so big that we would need to collaborate beyond that triangle?
Well, I think if I could, in some areas which are attractive development areas, we're already doing that. So if you take rare diseases, where for historical reasons many of the London centres act as the magnets for patients with rare diseases, and so we become the hub or the fulcrum for a national effort in that regard. The networks are already being established, and we need, given that attention to rare diseases, orphan diseases is becoming an increasing focus for pharmaceutical endeavour, then we need to take full advantage of those sorts of links. I'm a profound believer that if the UK is going to be competitive with nations that are investing far more of a percentage of their GDP in R&D, we have to work smarter, and part of that smartness is taking greater advantage of interdisciplinarity and greater advantage of collaborative networked ability, because we're a small nation in geographical terms, and it's embracing Oxbridge within the London interpretation is important in that regard as well.
I wonder if I could just complete, Eric, if you don't mind, if I could ask, because I really have worried about education throughout today, as asking if, not to do it at the moment, but whether you could give a very small written submission to the Commission specifically on this issue of the educational threat and opportunity in relation to life sciences, because I don't want it to go the way of the other things which Richard so eloquently described at the beginning. Is that all right?
It would be absolutely wonderful. Yeah, it would be wonderful. Yeah. And I think also the opportunities in, as some of the training sort of demand is reducing in the NHS, is how do we fill that supply end with overseas trainees, and what the issues that comes from that is.
So it's another potential market for us if the cap on overseas medical students, for example, were lifted, which some of us are arguing for. I think in educational terms we also mustn't forget the need to build capacity in areas which will support this life science endeavour. So bioinformaticians, for example, trialists, health economists, all areas where we're currently deficient. If we don't attend to that, we will not do half the job we should.
Sure. Thank you. Richard, you mentioned something about the Mayor taking responsibility for health of the London citizens. Could you elaborate on that? Because the Mayor's executive powers is to make sure that the health and well-being of London citizens. So he's very powerful in terms of the public health agenda, and one of our themes is that what you're referring to?
No. So if you go back, the Strategic Health Authority had responsible for the healthcare of Londoners, yes?
Yes.
And so they would work with the academic health science centres, but they would work with the deliverers. If they were still there, they'd work with the CCGs. But there is no centre anymore who's taking that responsibility. That is all gone. So the academic health science centres and their networks are critically important, but there's got to be someone who brings them together. Of course they will work together, but there's got to be a driving force. So if you think about big cities like London, which are very different in many respects from the rest of the country, you cannot just absorb them within a national service. And it seems to me that then has to go to the mayoral responsibility, as he should be responsible for lots of things that just are specific, if you like, to Londoners. So there's got to be somebody. If the Strategic Health Authority doesn't exist, who is going to take that role? I can only see one area, and that has to be the Mayor's office, who drives that process and is the leader in that area, because he can then set the vision, provide all these incentives to do the things that you want to do. I mean, we've gone through this process before. Livingston set up exactly the same kind of commission. He got all the groups together. We have something called what happened to the great Global Health Centre in London?
GMEC, you mean?
Yeah, with the device industries, the pharmaceutical industries, academia, the NHS. There were all the great players. What happened to it?
Okay.
So all these mechanisms, but there's just not enough energy to drive it and make it happen.
The CCGs wouldn't fulfil that gap.
The CCGs can't do that. No.
Okay. Is that your views, John?
Well, I think with every restructuring of the NHS, we find that the new commissioner body struggles initially to learn its role. And unfortunately, even though there is a remit that they look after research and education, that will always fall to the bottom of their priorities. So I think some are very engaged, but many, it's far from the top of their agenda.
Okay. Well, I can't thank you enough for a late afternoon to be here, and thank you, Richard, for allowing us to have this here, considering you're the chairman of the Royal Institution. So thank you very much for that. We had a wonderful day, and thank you for finishing. The finale was brilliant. Walk me up, anyhow.
Absolutely.
Thank you.
Any more help we can give you, we're happy to give it.
Much appreciated. Thank you.
Great.
Thank you very much. Thank you.